Okay, ladies and gentlemen, you're about to receive the world's first international medical podcast, hosted by 3 paramedics from different countries. Live from the UK, Finland and Australia, this is Group Call.
Very good morning, ladies and gentlemen. Thank you for tuning in. Now, is IO really superior access to the vascular system than IV? Is this really better than this? Or maybe this has limitations that we are not aware of, and actually this is better. Or maybe we use this because we're so used to and we disregard this, which is brilliant. We will find out in a moment. We will definitely change your thinking. We will definitely challenge some cliches. But without further ado, let's roll the intro. This episode of Group Call Live is brought to you with kind cooperation with Medic in the Middle podcast. So Tom Alderson, please follow him on Twitter. I will put the link below in a second. Tom is with us today. Good morning, sir. How are you today?
Good morning, mate. How are you?
Yeah, not too bad. Thank you. It's great to have you on the show. Tom posted and we posted the same survey 5 days ago. We asked our viewers and our listeners which way of accessing vascular access is better. Tom, would you mind talking our viewers and listeners through the outcome of the survey, please?
Yeah, no worries. I asked the followers on my channel out of intravenous or intraosseous access for out-of-hospital cardiac arrest, which is their preferred method of choice, and the results were actually really close. So 52% of people preferred to use intraosseous access and 48% preferred intravenous access. So really, really close results, kind of almost like split and, well, it's almost half and half.
Yeah, it's almost like in the actual medical world, right? You will come across people who love IO and you will come across people who love IV and will never ever drill someone else's bone. What is your personal preference, mate?
My personal preference is I really tend to prefer to treat on a case-by-case basis. As a general rule of thumb, however, I will opt for intraosseous initially to start, like any kind of initial drugs that need to be administered as part of the cardiac arrest management. And then I will kind of secure an intravenous access secondary to that initial IO later, well, when we get a spare second during the kind of initial stages of managing the ALS protocols. But if I can get an EJV, an external jugular vein, after I've secured that initial IO, then that is normally my kind of preferred practice, or even just a fairly large bore cannula into the ACS or something like that for kind of more larger volume fluid resuscitations. But I don't really see any I don't think it does the patient any disservice to get in an IO in good time. I did some research actually sort of prior to our chat today and found an article from the Scandinavian Journal of Trauma and Resuscitation Emergency Medicine, or SJ-TREM. There was a systematic review and a meta-analysis of some observational studies that they did back in March 2021 by Heisch et al. And they basically took loads and loads of studies from the Cochrane Library, PubMed and Embase, and sort of compared all the studies from IO versus IV access in a cardiac arrest out of hospital scenario. And they tried to look at sort of favourable neurological outcomes at hospital discharge as the primary outcome to either IO or IV. The meta-analysis that they did sort of revealed no significant association between the types of vascular access at hospital discharge amongst sort of neurological outcomes in the patient. So looking at kind of the evidence out there that I've taken a look at the moment, there's no kind of strict evidence I can find. I mean, you're going to be the man probably on this topic. You've had a lot more time and prep probably to have a look at it. But first glance, I can't find any kind of cut and hard evidence that suggests this is the better approach. If I can generally get in an IO in good time, preferably I tend to go for the humeral head, as it does have a higher flow rate than the tibia site, and it has like kind of there's been some studies to suggest that it has less difficulties in inserting, less complications, and etc. But I mean, I think it comes down to personal preference and whatever the clinician feels comfortable with at the end of the day. But for me, a humeral head IO, because it is a slightly larger bore needle and you do tend to get better flow rates, that'll tend to be my first point of call if I can. And then I said afterwards I might establish an IV access secondary to that site as well. So I have both, but it takes me slightly longer to get maybe sometimes an IV into a patient in cardiac arrest than it will do to secure an IO.
Okay, fair play to you. You guys just need to know that Tom just came off his night shift. Tom, did you drill or stop last night someone?
I did not. No, we didn't have a cardiac arrest last night. Nope, not in the last 24 hours.
Perfect. Tom, thank you so much for joining in. We've got some match for you. We'll send it straight after the show. Stay with us. We're going to talk about all those things you mentioned and a bit more. Tom Alderson from Medic in the Middle. All the best, mate, and good night later when you will get home after your night shift.
Yeah, thank you very much for having me on the show, matey. Thank you.
All the best, matey. Thank you so much. Guys, you can also call us on 0790 8000-947. You can call in straight to the studio and we can have a chat. You can also comment. So wake your fingers up if you're on the northern hemisphere, or put your drinks down and comment if you're on the southern hemisphere. Talking about hemispheres, Teemu Silva, from Finland, and Harrison Steed from Australia. Good morning and good evening, gents.
Morning.
Hello.
Ladies and gents, what we're going to do in a moment, we're going to compare this and this in 4 categories. We're going to talk about indications and contraindications. We're going to talk about insertion sites, benefits and risks. And now what we're going to do, we have, let me show it to the camera, the bin of doom. So after comparison in every category, the device that will lose goes to the bin of doom. And when we finish, we'll see how many devices we have in the bin of doom. So not really good. And who left on the battlefield. Are you ready? Let's start with the first category, which is guidelines. And now, let's face it, I think it's pretty simple. We don't have to discuss it very much because guidelines are very clear, aren't they, Harrison?
Yeah, they're pretty straightforward for most agencies and most services across this country, at least, and across the world. The only thing I'll add is that down here in Australia, a lot of the state-based services, there's not really quite a fair fight, unfortunately, because IO is often restricted to intensive care paramedics. They're often not able to do IO access unless it is in cardiac arrest. So any Australian listeners listening on might not have any direct experience or much direct experience with the IO. Yeah.
Teemu, I'm very sorry. Because what we need to know is we decided to have an IO advocate, an IV advocate. And Teemu here, Teemu is our dedicated IO advocate. I'm very sorry guidelines are clear. I went through European Research Council guidelines, and they say attempt IV, then consider IO. American Heart Association guidelines. Let's firstly go through ILCO. Outcomes may be better than if drugs are administered IV. Sorry, Teemu. And American Heart Association new evidence suggests some uncertainty about efficacy of the IO route compared with IV route. And I went through those evidence, the 4 quite serious research papers saying IV is still better than IO. Teemu?
So, someone's got to lose.
I think IO is really getting the short end of the stick here because, as Harrison said, guidelines are favoring IV heavily. Apart from just like restricting it to a certain like paramedic population, also the guidelines often advocate for using IV first or attempting IV first, and then if that doesn't work, then using IO. What ends up happening is you will spend 2 tries, 90 seconds, 180 seconds, however long, attempting that IV, and then doing the IO. And then when we look at the data retrospectively in these studies, IO is losing out because, well, obviously it's been placed later. So the drug administration has been delayed. So I think a quality random control trial like the Paramedic 3 is going to be will be much more useful in terms of like properly assessing the evidence base around IV versus IO. So at the moment, even though the studies do say IV is better, I do take some issue with that.
You had one good argument and you've used it 12 minutes in already.
Yeah. Don't worry, I've got more.
We'll see. We'll see, Teemu. Just to make our viewers and listeners aware, Paramedic 3 trial is a trial conducted by Warwick University on the group of 15,000 patients. They want to enroll 15,000 patients, and the trial takes place from 2021 to 2025, where they supposed to publish some outcomes from this study. We'll see. Keep the fingers crossed for colleagues from Warwick University. I know that my trust is already involved. My ambulance service is already involved. We were already trained in trail packs, so we'll see. Again, fingers crossed. So shall we put IV to the bin of IO to the bin of doom? I'm sorry.
I don't agree with that. I think, well, if you're going to put it, the guidelines have put it there.
And as we always say, always listen to your local
Always
guidelines.
listen to your local guidelines. And
There we are.
Bosh. And that's the first device in the bin of doom. But yes, we supposed to make this disclaimer. I'm sorry, Teemu, because Teemu asked me to make this very, very clear. We want you guys to always follow your local guidelines. By all means, if you have your preference and guidelines let you to do so, then just be on the top of your game and choose what you prefer. But if not, if your trust says, or your company or ambulance service says so, just follow what they say. Am I right, guys?
Yeah, for sure. And also, like, we're discussing studies and I was discrediting them. That's mostly just for laughs. Read the studies, make up your own mind, read the conclusions. We don't mean to shit on anybody's studies or anything here.
How funny.
Absolutely
not. Cool, guys. So if we have the first thing discussed, I just need to do something with Harrison, because your picture, mate, jumps all over the place. Yeah. You most likely noticed, guys, that Harrison is outside. It's 30. How hot is here in Australia?
Oh, it's a bit cooler. It's a bit cooler now. It's probably 34 or something. But inside my house, it was roasting. So instead of perspiring all over the camera, I thought I'd sit outside in the in the lovely nature of here.
Let's move on.
I am undercover.
So let's try and find out indications and contraindications. Bosch. Over to you guys.
So yeah, I'm going to take the lead here with this time. So in terms of like the indications and contraindications, indications, especially in cardiac arrest, are basically the same. We need an access, we need the medication delivered, adrenaline, amiodarone, most likely, sometimes something more specific. And then we might need some fluids, might need some blood products, TXA, stuff like that, especially for traumatic arrest. The contraindications, then again, for IO, is basically a fracture in the same side or the same limb that you're trying to do the IO in, and then some like local problems like burns, infections at the site where you're trying to do it. So then you're not supposed to do it through an active infection, and also like some rarer ones like osteopetrosis, which is just like brittle bone disease, basically. So it will increase the fracture risk. There have been some studies saying you shouldn't be doing it to children near the growth plates. But then again, there have been other studies that have actually done it through the growth plates specifically, and then followed up for like 6 months to see if there's been any problems to the growth plate itself, and there hasn't been anything. So the jury's still a bit out on that in terms of children.
Yeah, so IV is obviously, fairly similar across those indications and contraindications. So we need vascular access, we need to administer medications, fluids, products, as Timmy mentioned. And the contraindications are very similar as well. You don't want to insert an IV in a limb that's sustained major trauma, because that vein may well not be going anywhere. And any other sort of damage or infiltrates that might be around that side there. So I feel like, again, this is more my bias because I'm trying to fight this side, but I feel like there's probably more instances in where IV is going to be indicated in the conscious alert patient that's uncomplicated, but then later arrests, as happened the other day. You're already going to have. We'll hold off yet. You're like, for those patients that do arrest on you, you may already have it ready to go. They're a lot less. They're equally invasive, but they're a lot less painful. And lower risk of complication as well, typically. A little bit lower risk. So I think IV just nudges it just a little bit on this one here.
I think there's one more indication that I actually leave out on purpose, and that is the indication for IO is also if an IV attempt is not successful, or if you are unable to acquire IV. So basically, IO is the safety net for us, is the safety net when IV fails. And I would also argue that IO, if it has been practiced, it will never fail.
Oh, come on.
Whereas IV
come on.
That's,
no.
I don't know. Look at the rates, I don't know if that's really safe to say, but look, you are right in that it's the last line of defense. Essentially, it's that backup plan, that plan B. Plan B, like if it was good enough, it would be plan A. But anyway,
I think like the success rate is only low because you do IV and like less sickly patients and like alert patients and outside of cardiac arrest, you practice it. You basically do like 5 every shift or something crazy.
Maybe in Finland.
Yeah, but you have to do you rarely do IO, and if you're not in a good spot, like I get to practice it almost weekly in a cadaver sort of environment when I'm working, but most people can't. So then it's obviously going to be less successful if you haven't practiced it. But if it has been practiced, it is really quite easy. That's why it's
The other
called
thing that
CIO.
the other thing that we have going for us down here, and perhaps in 5-10 years when we have this discussion again, the circumstances will change. But obviously, a lot of aeromedical services have been using ultrasound for quite a while in various aspects. But we're running a feasibility trial at the moment for on-road paramedics using point-of-care ultrasound, and particularly looking at vascular access and seeing how it benefits that. So that's that cohort of patients where you're unable to get that IV may be diminishing slower and slower and slower with the point-of-care ultrasound. So there may be less of a space for your beloved IO. We'll see how we go.
So you need like a $5,000 piece of equipment to get IV, whereas I need my two hands, find where the thumbs collide, and then drill there.
It's not a one-use product.
Okay, fine, that's true.
Yeah, but it's quite important thinking about environment when you dispose this plastic or when you dispose this with battery and stuff. So I would still say that with indications, contraindications, we use more of this, but they are safer for environment.
To be fair, you don't discard the drill after use, so it's not a fair comparison.
Okay. So what should we put into the bin of doom?
I think Timo and I have made up our mind, so you need to be the tiebreaker.
I think it's going to have to be you, Alex. It has to be you. It's like you need to be impartial.
Me, impartial. Okay. Okay. The argument which bought me is that it is our last caster's stance, last defense. So let's put.
I will concede.
Let's put IV to the bin of doom. And now.
Nice.
And now, let's go through the next chapter. So, insertion sites. And I looked through insertion sites of the IV, and I ought to compare it. And if you think about, let's go with drill first. You've got proximal humerus, proximal tibia, distal tibia, sternum, and iliac crest. Now, 1, 2, 3, 4, 5. Now with IV, you can stick it in basically any vein anywhere. And I don't know if it's the really best moment to confess, but once I had to obtain an IV access on very personal vein, on the very personal space. It was unfortunately very over 90% of burnt skin. So we could not place IO on any of the sides, and I had to find the vein, and I found one down there. Hence why my voice, my I would opt for IV, always IV, which has more insertion sites than IO. Teemu, happy with it?
Yeah, I think you're correct in that IV can be inserted into basically any vein. Obviously, you've got your ACF and the peripheral veins on the hand, and then EJV, as we were discussing before, external jugular vein, which is a bit rarer to do, but it is a big one and probably a visible one. I think where you're omitting something is that in a cardiac arrest, if we're discussing IV versus IO in a cardiac arrest, it's that you will actually find a vein like on a finger or on the back of the hand, and even if you do, will you be able to insert a large enough cannula in there to actually be delivering good amounts of fluid and good amounts of medication quickly? And also, the more peripheral you go with IV and with IO as well, the more time it's going to take, most likely, for the medication to reach the heart and enter into the arterial circulation. You will only have a few IV sites for cardiac arrest, really.
Now, okay, so let's think about the flow through the insertion sites of the IO. they are not equal, right? Because what you need to remember is that flow through humerus will be better or different to the flow you have in tibia. And also what I need to remind you, Mr. Silver, is that you have this medular pressure, which you need to overcome with IO. So the pressure in the vein is what, 6 to 10 millimeters of mercury, and intramedular, is that the word? Intramedular pressure is 1/3, 1/4 of the systemic pressure. So you have to overcome this, and you have to actually really strongly push. And if you want to run the fluids, you should have your BP cuff around the IV, because otherwise it won't really work. So hello.
Yeah, we actually carry like a proper pressure bags to use, especially if we're doing an access site at tibia. Humeral head, it's much more allowing in the medullary pressure that you have to overcome. But in terms of like the tibial sites, even in like they have done studies, and they noticed that in a hemorrhagic shock, there's like a 30% decrease of flow, like in the peripheral bones and in the medullary cavities in those bones. So the flow from below the diaphragm is not going to be that good. But to be fair, I mostly do humeral head, so I don't think that's still that big of an issue, really.
Yeah, but hold on. Sorry, Heiser. I just need to say something to Temo. If you absolutely humeral head, far better. However, can you do it on your own? Not really. You need someone to stabilize the limb. Whilst EGV, you can easily do it on your own. I did it few times. Sorry.
If the patient is in cardiac arrest, I think they are pretty stable and still.
No, come on, Harrison, say something.
Well, the argument that IV is inferior because in a out of hospital cardiac arrest you have fewer viable sites. I mean, yes, the sternal IO is going to be the superior site in terms of flow rate and ease and complications and the like, but when you've got a busy scene, you've got a tube patient, you've got your core pulse Lucas device, or your person doing chest compressions. It's going to be a bit logistically difficult to get to that sternum as well to do that IO. And are you going to be compromising compressions as well? Like, are you really going to be, unless everything's falling your way in a perfect world, are you going to be using that optimal site of the sternum to get that access? And in which case you have to go to the humeral head. But even then, you're quite close to everything going on. The benefit about the ACF is that you can be kind of away from the action, as it were. You can move the arm a bit laterally. It works. That's a good 1/2 meter, or 1.5 feet, depending.
Maybe 30 centimeters.
30 centimeters.
50.
Maybe in a ped. Yeah, 50. We'll go 50. We'll go 50. So, but again, if you're we're often using the core pulse with our out of hospital cardiac arrest at the moment, and it's a bit of a bulky unit, and it can sometimes cause some issues with access, and particularly recently with decompressing a chest while you're trying to reach over the apparatus, it makes it a bit difficult. So, that ideal site of the sternum, sometimes not going to be as accessible as you'd like. So, using the argument that there's going to be less viable sites, well, you're only really looking at that humeral head
and
as well.
just letting our viewers and listeners know that there is a really good study, and we will leave the links to all the studies we mentioned in the description to the video when it's recorded. Pasley et al. Study from 2014 shows that the sternal IO provides the best flow, even better than humeral head, which is quite understandable. But again, as Harrison said, you cannot really, you can try to obtain it in cardiac arrest, but is it really, so what's the word? useful in cardiac arrest, and humeral head success rate, that's the next interesting one, is really poor. So only around 60% of humeral heads are actually done properly. 60%, hello, and that's Reed's et al. Study. And the dislodgement percentage is very, very high, around 33% of your favorite humeral head, Mr. Silva, will be dislodged.
So I think Timu's previous argument then that when it's done right, it doesn't fail. You can say that for just about anything, but obviously it's not always done right. I'll let you go on. I'll let you go on.
Oh yeah, I was just about to say that we have a different like a topic coming up where I want to present my arguments in terms of dislodgement, because that is obviously a risk with IO. But in terms of the sites, I think the sternum is not a viable site in a cardiac arrest. We use Lucas device, and I don't think it would work with the sternal access site. But from the ACF to the humeral head, not that much difference.
No, you put your fast IO here. You put your Lucas slightly
higher.
Yeah,
up, true.
So hello.
But still, the humeral head, the success rate is most likely low in that study, just because it's a retrospective study and they haven't controlled any of the training, any of the practice that the paramedics that did the IOs in that study have done. So if you get to practice it a lot, it will be a lot better as well, and the success rate will be higher, and we'll come back to the dislodgement as well, because I've got a trick for that. How do you keep it in?
The same argument can be made for IVs as well. The more you practice them, the better you're going to be at them. You mentioned before it's a very low volume skill. We're not doing 5 IOs in a shift, so that speaks more to this. You really.
But it's so easy. You don't need to. You don't need to do 5 per shift.
Well, you don't need to, but a 60% success rate, maybe you do need to do some more or do some more training. And if this need for more training is really there because of this low success rate, then why aren't people training at that? Because they think it's easy. They go to a cardiac arrest.
Well, in terms of like raw numbers, if we're talking raw numbers of insertion sites, IV, I will give it to the IV, and I think save my ammo for the next category.
Bean of doom, the bean of doom. Okay, that's where IO goes. Sorry, not sorry. Let's go through the last category. Risk versus benefits. Teemu, any ideas?
So the benefits, the clear benefits, and which is also why IO is going to win this category, is that it's super fast. You prep the line. You can even prep the line while you're running to the scene if you got your kit inside the cabinet of the truck.
Do you really? Do you really have?
Yeah.
Seriously?
Why not? You could prep it.
Oh, you can have it on you can have it as a gun, right? In your holster. Hello.
You could even have the drill in the holster. Yeah, but
No.
like prepping the line, when you go in, you just need your landmarks. Pop the bit in, drill, and Bob's your uncle. It's in. It's arguably way faster than IV can possibly be. And if IV turns out to be difficult, then IO will clearly win in terms of the benefits. Other benefits include that it can also be used like a temporizing measure to getting an IV. Even like we're discussing cardiac arrest, but in a patient with like hypovolemic shock, you're not going to be finding any veins unless you're using a point of care ultrasound maybe. And then you can actually pop in an IO, give them fluids, give them vasopressors, stuff like that, and then get the veins showing and then
upgrade to IV.
you can obtain secondary access, and then you have 2 access points. In terms of the risk, though, like I said, the dislodgement is a risk. What you're going to be moving. If we're talking humeral head, if you want to do like thoracostomies, you're going to be like lifting the arm up, and there have been cases where that will bend the needle and it will dislodge it and it will not work anymore. So there is a trick to it, and it's like probably rarely taught. But what you need to do is you need to internally rotate the arm, and then you can lift it freely. So you need to turn the thumb basically facing downwards, and then you can lift the arm. And it's been done in cadaver labs and shown to work in preventing the dislodgement. For Luke's device, you also want the hands up on the device, but you don't need to do it. You only need to do it when you're transporting a patient. So then you could have an IO in the humeral head and also in the proximal tibia, for example, or the distal tibia. And then you have your backup. You can do 2 IOs at the same, like in the same time period as you're doing 1 IV in a cardiac arrest, so it's not an issue.
It's not true.
You would only need that 1 IV.
Not for trauma patients, though. You need 2 large bore IVs.
But
it's still going to flow much better than your tibial.
Oh, absolutely.
If you're needing large volume.
Yeah,
and I know it's not for our pre-hospital setting, but in terms of in-hospital setting, you can actually take all bloods from freshly inserted cannula. I'm not talking about old cannulas inserted a few minutes ago, a few or more than a few minutes ago. I'm talking about freshly inserted cannulas. You can take bloods. Whilst for this device, if you will actually use IO, you still can get hemoglobin, hematocrit, glucose. You can do cultures and electrolytes. But for example, you cannot do full blood count. And if you won't label the blood from the bone marrow from IO correctly, it can actually destroy or break the machine in the lab. So IV?
That's why you do it correctly.
Harrison, just hold my hands.
Look, I think another big benefit, and I don't like bringing this up in terms of medical treatment because it shouldn't be a consideration, but it has to be, is the price as well. Like IV is so ubiquitous and so cheap that's a big factor as well. So a lot of these, we all work for reasonably large services, well-funded services, particularly in America, and perhaps just later on in her video. A lot of these fragmented services, these volunteer agencies and the like, they might not have the money, the funding to afford IOs and all these fancy bits of equipment, but you can bet they've got some IV cannulas there ready to go. So for the most part, these large services, it's not too big of a deal. And the training as well, the training cost as well. But the price needs to be a big consideration as well on a system-wide consideration. As well as the fact, I've already used this argument, so it's a bit of a cheat, but it's so well practiced as well. Like how many times in a shift or in a week are you doing an IV? It's just second nature to us. You almost don't need to practice it because you are doing it so much versus, with the exception of external jugular. That one needs to be practiced because you're not doing that very often. But with IOs, you're not doing it nearly as often. Yes, the actual process, the procedure is faster and easier, but you still need to practice it a lot more and spend the time to actually practice. And how many other things do we need to practice as well?
That's true, but the good thing about IO is that you can actually practice it in a cadaver-like environment. You can't really do IVs in a cadaver lab. Well, you could basically feel the veins, I guess, but that's a bit dodgy. We do more IVs. so it's more practiced. But do we do more IVs in cardiac arrest though? Because doing an IV in a cardiac arrest is completely different to doing a IV on a like a subacute patient just for like giving them fluids or something.
I mean, I've only got the benefit of working for my service where intensive care paramedics have the jurisdiction and intraosseous access. So, yeah, we most certainly go for IV as the first instance in the vast majority of cases. So, yeah, in our circumstance, not really. But if, an equal playing field where you've got both devices in access to you, then, yeah, I can see that is a good argument, specifically in cardiac arrest. But also there's many cardiac arrests that don't start off that way. Well, I suppose all cardiac arrests start off with the person being alive, but they don't always start off when you get there.
The also like there's one more, but it's more of a niche benefit from IO is that like in the northern hemisphere, especially it's -1 degrees outside right now. If the patient has been in the cold water, drowned in the cold water, fallen through ice or something, or has been outside for a while, they're going to be cold really fast. The veins are going to be even more hidden on a patient like that.
Hold on. What is this hypothermia protocol? You don't give drugs if they are...
But you need the access.
What for? First, you need to warm them up to give drugs, right? You don't give drugs if they are below 28. Sorry.
Well, okay, fine, not 28, but 30, 32, 31, 32. The veins are still going to be really
Harrison, just look what he's doing now. So your patient needs to be not only to the icy water through the ice. So his core temperature should be above 28, and then you can drill.
Very specific circumstance.
No, they don't need to be, but they can be, and it will still work. Whereas IV won't.
You'd find a way.
Okay. So let me bring some research papers here in terms of risks and benefits. And I agree with you, Teemu. Speed. Let's say that speed is on your side, so you can quicker get IO in. Absolutely. But what about the risk of emboli? And it's a huge risk. And all other viewers and listeners, if you want to later go to the links below, please read Rubal et al. Study with the massive risk of emboli. That was on animal model, but basically almost all animal models included in the study got the emboli. Hello, and extravasation as well. If your IV fails, you can see it almost straight away. It's not that easy with IO. Bosh.
I think animal model studies as a proof when we're discussing human cardiac arrest is stretching it quite a bit.
Look who's talking about stretching, Mr. 31 degrees. Fallen through ice. So it's time for the bin of doom, and I'm sorry, Teemu, but are you both happy? I mean, I know Teemu is not happy. Harrison, agree?
I'm very happy.
I have to say, I think the judge is really partial to IV at this moment, because I think I'm arguing with two people.
The judge might be partial, but so is all the literature.
Thank you, Mr. Step.
Until the paramedic free trial comes out, that's all we can go off. Alex is God in this situation.
So before I'm pretty sure you all know the outcome of the comparison. But before we will do it, let's quickly jump across the pond and see the American point of view. Gina LaRue-Wendy, straight from United States of America.
Hi, everybody. This is Gina LaRue-Wendy from United States of America in St. Louis, Missouri. Today's topic is drill them or stab them. I guess we kind of are stabbing them in a cardiac arrest situation. So I work for 2 agencies in the St. Louis region, and when we speak about St. Louis, there's multiple different regions, different agencies, as well as the United States, different states, different regencies, different protocols, different licensing. So please follow your local rules, regulations, medical direction, and guidelines. All right. So with one company I work for, they're on the adult cardiac arrest is an IO. An IO is the Easy IO gun, which is the name brand of the device that we use, and it goes into the humerus for an adult patient. The secondary location would be the tib-fib region, and that's just in case like there's mass chaos at the top of the body, you know, if you're thinking about it, CPR, mechanical or manual CPR, and then you got the airway management. So a lot of people don't feel comfortable with that. Either way, if you go down to the tib-fib region and use that first, no problem. The pediatric patients with that same exact job, we use the tib-fib region. The tib-fib region is good for many different reasons, but there is some cautions, specifically in younger patients like neonates, infants, newborns. You want to be careful not to go through the entire leg itself in that tib-fib region, and then also to not forgetting to splint that extremity as well. My second job, they prefer first if you see like a honking IV, like great veins, AC is beautiful, EJ is amazing, then go ahead and start that IV first. Then if you fail that first attempt, then go ahead and do that IO. The humerus is the #1 location for the adult patient. And then again, uncomfortability, think about multiple reasons why, then you might start with that tib-fib, and that's okay. For that pediatric patient, anybody underneath the age of 6 gets a distal femur. Yes, I said distal femur. So that's 2 fingers above the knee. You feel for that flat spot in the bone and go ahead and straight down drill with that Easy IO. Stabilize with a commercial device or bulky dressing. And then that secondary, anybody over 6 years of age, or if they're like a larger kid, then go ahead and do that tib-fib region. If they are like a man-child, woman-child, those larger teenagers, you're going to do that humerus IO right up in that same location. It takes milliseconds for that drug to get into that systemic body, so which is our goal in mind. Any cardiac arrest, also to think of trauma, if it's trauma related. If we start like an IO or an IV in a limb that has like a gunshot wound, it might not be effective because you could be pushing these medications and it would just be flowing out of their body. So you still have to do that full body physical exam to make sure that that placement of the IV and IO is appropriate. So I hope you guys have a great day, and I hope you stay warm and safe. Thank you. Bye.
Thank you, bye. And you guys, please remember to call us on 0790 8000 947. I can see that there are plenty of people commenting on the YouTube and Facebook. Thank you so much. That's really good. That's why we wanted to start group call, because of you guys and your opinion. Getting back to my noble colleagues here, shall I open the bin of doom?
I don't know, Tim, who do you want to see?
Dun, dun,
No,
dun, dun.
no, I don't. I think we can skip this part.
We have 3 IOs and 1 IV, so we left with 3 IVs on the desk, which means that, according to us, IV is still a bit better than IO. But guys, jokes aside, as we said on the very beginning, we had this conversation to compare our personal preferences and also the literature. But by all means, follow your local guidelines and protocol. And if you have this allowance to go IO or IV, then by all means make sure that it is your informed choice backed by the literature. Am I right? Yeah? Or that's what we wanted to pass?
Yeah,
Absolutely.
definitely. Because like, even though, as we said, even though the literature at the moment favors IV, it has mostly been retrospective, and there's lots of variables that have not been able to like controlled out of the study. So like sites, fluid flush, pressure bags, training, and also like paramedic selection bias. So which patient am I going to be doing an IO on, and which patient am I going to be doing an IV on? They did propensity scoring to rule out like really bad cases getting an IO and easier cases getting an IV kind of stuff. But even still, it's a bit like up in the air, at least until paramedic 3 comes out.
And Tom said right at the start as well, he was very diplomatic and sat on the fence, but it's a case-by-case basis is what he said, and that's absolutely the case with this. There are going to be some instances, I will concede, where an IV is not the most suitable, but it usually will be. Use what is best for your patient.
To be fair, like if I see a bulging vein, like an ACF or something, when we go and do a cardiac arrest, it's probably going to be the IV that I'm going to go for, just because of the like the ease of securing it in place, reduced risk of dislodgement or bending. It doesn't bend, or if it bends, it will bend back as well, whereas the IO needle will just stay that way. So yeah, IV if it's possible for me, if I'm like forgetting the role of an IO advocate here, but IO is super easy and super fast when you do require it.
When you do it right, that's what you always say.
Well, we never do anything wrong, so obviously.
Obviously, but yeah, I would love to see Teemu with the 2 IOs in his holster actually placing the vein.
Yeah.
And guys, message from me, I was heavily trained on external jugulars. If you train, do it. It's such a nice vein and easily accessible, and you can later on manage, before then you can manage airway and then get the AGV. It's really good if you know how to do it, and if you were trained. Harrison, what is going on today with your picture, with your stream thingy? I cannot. Yeah,
still bouncing around.
Yeah, it's still dancing around. Anyway, ladies and gents, thank you so much for watching. We really enjoyed today's episode, and if everything will be fine, we will see you in 2 weeks. Teemu Silva, Harrison Steed, Alex Hepner. This was Group Call Live.